Okay. Yeah, let's just check people can hear us.
Okay, hi everyone.
Recording in progress.
I'm hoping people can hear me on mine.
Still an echo.
We still have a bit of an echo problem.
I didn't want to join. Okay. Okay. We're good. Should be good now.
Oh, great. Thank you, Courtney. So welcome everyone here in person and online to our University of Minnesota Department of Psychiatry and Behavioral Sciences Grand Rounds. This is the first one in this academic year. And I'm really excited to have our speaker, Dr. Helena Hansen. And just to give you a bit of a context, I'm a psychiatrist here in the faculty, for those who don't know me, and I'm part of the wellness team, and we've been organizing webinars that bring the DEI or the diversity, equity, inclusion lens to wellness as well as health in general. And in that context, I learned about Dr. Hansen, who is a friend of Debbie Cohen, who's our yoga and mindfulness teacher, and they go way back. They know known each other for a long time. So thank you, Debbie, for making that connection. And just learning about Dr. Hansen's tremendous work in this area on intersection of race and addiction. We were lucky to bring her here for the Grand Rounds. So a little bit about her background. Dr. Hansen is an interim chair of psychiatry at UCLA David Geffen School of Medicine. I actually trained in residency, so it's really neat to have you come here and bring a little bit of sunshine with you. She earned her MD and Ph.D. Degrees in cultural anthropology as part of the Yale University's NIH-funded medical scientist training program. And after graduate school, she completed a residency in psychiatry at NYU Medical Center, Bellevue Hospital, during which Dr. Hansen also undertook an ethnographic study of the introduction of new addiction pharmaceuticals. She examined the social and political implications of clinicians' efforts to establish addiction as a biomedical rather than moral or social condition, as well as the ways that neurochemical treatments may be reinscribing hierarchies of ethnicity and race. She created a documentary based on this work titled Managing the Fix, which was shown at one of the annual meetings of American Psychiatric Association in the recent past. Dr. Hansen is also author of 3 books. One is titled Addicted to Christ, Remaking Men in Puerto Rican Pentecostal Drug Ministries. Another book titled Structural Competency in Medicine and Mental Health, a case-based approach to treating the social determinants of health. And the latest one, which we have here,
Is Debbie's copy, but
thank you. Whiteout, How Racial Capitalism Changed the Color of Heroin in America. And with her work, Dr. Hansen has received numerous awards, including an honorary doctorate from Mount Sinai School of Medicine in New York, and also election to the National Academy of Medicine. So I'm really excited for you to talk.
Thank you.
Welcome.
Oh, thank you. I think I'm supposed to turn camera on. Is that right? There we go. Okay. What a thrill to be here and to kick off the academic year. I just calculated in my head that Debbie Cohen and I met exactly 35 years ago.
Oh, wow.
I know I'm not supposed to say that in public, but as college freshmen, and it was probably just after Labor Day, right? So it's been 35 years. So first of all, I want to thank Debbie for all things good, all the positive psychology that I have absorbed from her since she was 18 years old, as well as what I know of yoga, and for arranging for me to be here. And I also want to thank you, Lydia, Dr. Zalowska. Thank you for not only making it possible for me to be here, but for all that you're doing for mindfulness training, integrative medicine, and psychiatry. Really, you've had such an impact nationally, internationally. Thank you. Also, Sophia Vinagrada, thank you for leading a department that really values social determinants, mindfulness, integration, not common. It should be much more common in psychiatry. And also thank you, Daniel Franks, for making all this possible. I'm sure there are many, many more But I just wanted to acknowledge that it's so exciting for me to be here, and no small effort on your part here at the University of Minnesota. I'm going to share a story that goes back almost as far as my friendship with Debbie Cohen. Sadly, we're now seeing as if it was possible to have higher overdose rates in this country, just internationally historic high rates of overdose deaths in the United States. How could it possibly get worse? We ask ourselves in psychiatry and addiction medicine every year, and every year it gets worse. So this is a story that I've been watching unfold since literally I was in college, and definitely from medical school on, and it continues to evolve, especially in terms of the demographics, the racial imagery around who is dying of overdose, that continues to evolve. I'm an addiction psychiatrist and also a cultural anthropologist, as you just heard, and my work has really focused on the institutional logics shaping health inequalities. To what extent does what we do, even in clinical practice, drive these racial inequalities? And also social approaches to promoting health. I call them social technologies. I count integrative medicine, mindfulness, yoga in that category of social technologies that have even more an evidence base now than they did when I was training in medicine for their effectiveness. So that's been my focus all along. And today I am celebrating my book. Thank you for the unpaid advertising for my book, which was released just a few months ago on UC Press. I think I was supposed to share my screen. Let me do that now so that I can launch into my story. And I have to make it full screen. Give me a moment to do that. Okay. All right. So forgive me the indulgence here. I put the book cover because I'm, still.
Sorry to interrupt. I need to change the view because people are still seeing the.
Oh, sure.
view.
Okay. So should I pause for a second?
Host. If you can just change your view, it's like view host.
You know how I can do that.
Sorry.
This is a good learning moment for me too.
My problem is I don't actually encode when people do these things and teach me how to do it.
Right.
View.
Somehow it was working before when we tested it.
Is there a new message that said never mind? Yeah.
It was Sabina, yeah.
No, I'm not on it.
All right, I'm trying
Is it
to.
possible for the audience to see the speaker?
Yeah, that's what I'm trying to do. See speaker view.
Slides, it says.
Well, slides should be okay,
Oh.
right?
No, I think there was
Same.
for a moment they couldn't see.
They can see, we're good.
Yeah.
They can see.
It looks like it's
Yeah,
sort of-
just talking.
Yeah, just because this is the one that they can see.
Okay.
Yeah, sorry. Okay, we'll leave it how it is.
Okay.
Sorry.
No problem.
And if you took her laptop off mute, it'll show you with the primary speaker as well. So if you switch so that the audio is through your laptop.
No,
instead,
we can.
You can do that. Okay.
Oh,
Because it'll echo.
okay. Well, thank you for your patience, everyone. Should I keep going?
Yeah, sorry.
Okay. All right. So this is the self-indulgent moment because they can see the book cover. Since the book just came out, my co-authors and I are going crazy with the book cover.
A lot of requests for interviews.
Some, yeah, some. And so, in the book, there's been a lot of coverage of the overdose crisis for sure. And there's actually been a lot of coverage that invokes racial imagery, which I'll get to in a moment, but there hasn't been an analysis of that racial imagery, which very interestingly brings into view whiteness, and what that signifies in our culture. And so in the book, we use the term racial capitalism in the title, and I spoke with some of the residents just an hour or so ago about that concept, racial capitalism, in relation to another concept that's pretty popular now, deaths of despair. So I'll get into that in a moment. But racial capitalism is the concept of making profit off of racial hierarchies. It's something that our society was founded on, actually, when it comes to what happened with race-based labor markets, slavery, indentured servitude, and then land property rights. And here we're sitting in the seat of a lot of Native American communities that have experienced this directly. But now we're in an era of bioeconomies, where racial stereotypes are being invoked to profit off of pharmaceuticals and things that we use in our own psychiatric practice. And so this is a story of racial marketing and racial capitalism, the use of racial stereotypes about, for example, who's prone to addiction and who's not, and segmented marketing of new treatments for things like addiction in racially segregated markets and neighborhoods. So this is built into the logic of our healthcare institutions and drug policies. And what I want to argue is that it ends up harming white Americans along with non-white Americans. This is something that's harmful to us all. And that's one thing that the story of white opioids is just one illustration of racial capitalism really shows us. So the US is in its third decade of this overdose crisis. It's not solely, let's see if I can switch slides. Yes, okay. At this point, we're calling it overdose crisis because it's not just opioids, as you probably know, those of you who are on the front lines of clinical care. And this is a graph that was published in JAMA Psychiatry last year. An MD Ph.D. student that I worked with at UCLA did this analysis with a national database. So we're seeing, and you might notice that it is, well, in a moment, I'm going to show one that's broken down by substance, that's causing overdose. And you'll see that that pattern is changing. But here, what you're seeing is the demographics of who's dying of overdose. So we're seeing a replay of something that's happened in US history, prior overdose crises that began with legal white medical narcotics and then moved over time to Black and brown street markets as the toxicity of the substance became apparent. And as racially targeted drug policies pushed the toxic substances into marginalized communities, selectively criminalizing them there, while preserving the biomedical responses for white, middle-class to affluent patients with access to doctors. So, what you can see here that Black Americans and Native Americans are dying at the highest rates of overdose, and they surpassed, as of 2020, they surpassed the death rate of white Americans. But really the bottom line here is that Americans from virtually all racial ethnic groups are only dying at higher rates now than they were before. So this is really underscoring how the system I'm about to describe harms us all. The epidemiologists that I work with.
Your laptop so they can see you and not your
Perfect. Thank you. Okay. So the epidemiologists that I work with identify 4 waves of overdose since the late 1990s. The first wave, this is a familiar story, it was due to prescription opioids. The second wave was due to heroin, as prescription drug monitoring programs and tamper-resistant formulations of prescription opioids made pharmaceutical grade opioids harder to get and to inject or snort. And then the third wave was due to fentanyl and other high potency synthetic opioids that quickly replaced heroin in street markets as cartels discovered the advantages of more potent, lightweight opioids over heroin for smuggling. And then it quickly became obvious that Black and Native American people were disproportionately exposed to fentanyl, as the more socially marginalized consumers of street supplies of drugs had less control over the contents of their supplies. They weren't so easily able to go to a doctor or even buy pharmaceutical grade or safer supplies off of trusted suppliers. And this is the weeks to months right after incarceration. Release from jail or prison are especially sensitive time. That's when a lot of people die of overdose deaths, because it's a moment where if they had opioid dependence before going into jail or prison, that tolerance is worn off. They're released into a situation where by definition, they have even less access to medical care, social services, housing than they ever had before incarceration, and their risk of relapse is very high. The fourth and current wave is polysubstance use. So this includes stimulants, and these stimulants may be cross-contaminated with fentanyl and other synthetic opioids, with stimulants driving much of the increase in overdose among Black Americans and Native Americans, who are often trying to limit their exposure to fentanyl. So ironically, people are trying to avoid the harms of fentanyl may be exposing themselves through contaminated supplies. So ironically, the current excess Black and brown deaths from street supplies of stimulants and fentanyl originally derived from what I call technologies of whiteness. And I'm going to go through that in a moment, that were originally used to promote prescribed opioids. And while Black and brown deaths are nothing new in the US, what makes the overdose crisis of the last 20 years different in many people's minds is, of course, the way that the white identity of the sufferers, the people who were dependent on opioids, has been highlighted in media and in policy. So I'm going to approach race and health from an angle that's unusual in medicine by looking at mechanisms of whiteness. You know, often when we talk about racial health inequalities, we start with what's happening in Black and brown communities rather than what's happening in white communities, and with images of white patients and consumers. So I'm going to share a case study of the hidden but active maintenance of white exclusivity in medicine as the cause of what we often call health disparities among quote unquote underserved minorities, groups typically described in a passive manner as lacking access to care. So whiteness is central in our environment in the US of profit-oriented healthcare commodification, the use of racial hierarchies to segment and open markets. And it involves the mutual racialization of drugs and people. So drugs can be white, you know, symbolically white, as in targeted to white people. They can pharmaceutically enhance the whiteness of people whose privilege may be in question because of a stigmatizing diagnosis like addiction. I first encountered office-based medication for opioid dependence in the late 90s. So I was a medical student. This was about a decade after I first met Debbie. And I was working on the early clinical trials of buprenorphine, which would later be manufactured with naloxone under the commercial name of Suboxone. I'm going to get back to this in a moment. My attendings were excited about buprenorphine, which they said was about to change the culture of medicine by defining addiction as a chronic disease, treatable alongside diabetes, hypertension, asthma. This was the brain disease model, and treatable in the same clinics, primary care clinics, in the same way with long-term pharmaceutical maintenance, kind of along the lines of diabetes maintenance. This really caught my ear, you know, working as a medical student in these clinics. I was an MD Ph.D. student training in cultural anthropology, so I wanted to know what could it mean to change the culture of medicine and what would drive this change. As it turns out, my attendings were right. In the course of my career, I witnessed a profound change in the way that clinicians frame addiction. And my field of addiction, so this is kind of backdrop. This is the series of years where I was training in medicine and psychiatry. My field of addiction treatment swang from a drug-free philosophy in the early 1990s to opioid maintenance as first-line treatment by the 2000s. And as I completed an addiction fellowship and I took a faculty position in psychiatry and anthropology, I also documented stark differences between buprenorphine patients on one hand and methadone patients on the other hand by race and class. What began as a study of the culture of medicine became a study of how the opioid crisis came to be seen as quote unquote white. Ironically, at the same time that racially targeted drug war policies led to mass incarceration of Black and Latino Americans, giving the US the highest incarceration rate in the world. While narcotics have long been criminalized through association with marginalized racial groups, such as turn of the century images of Chinese opium dens, Negro cocaine fiends in the American South, this is from 1914, Mexican marijuana madness. So this idea of especially illegalized drugs being associated with Black and brown others goes back a really long way. We don't often look at how symbolic association with white middle class markets has legitimated widespread prescription of narcotics, including post-World War II epidemic overdose from barbiturates and benzodiazepines that haunted white middle class America. So some of you may have heard of Mother's Little Helper. By the 60s to 70s, that's how benzodiazepines were referred to. So we rarely ask how a drug can assume whiteness within a pharmaceutical logic based on race. And yet this process of pharmaceutical whiteness is at the core of a widely asked question. And I happen to know that the residents, oh my goodness, you University of Minnesota residents are a very sophisticated crowd and they make time to read books. I'm so impressed, but apparently Deaths of Despair by Anne Case and Angus Deaton, the authors of this widely cited article, was on the reading list for the residents book club. So, you know, the question that this article in 2015 prompted was, why did the life expectancy of white Americans suddenly fall in the first 2 decades of the new millennium, while the life expectancy of almost every other racial group in the US rose? I say almost because it didn't for Native Americans. But how did overdose become the primary immediate cause of excess death here? So I'm going to go beyond the received wisdom that unemployed white Americans in the post-industrial Rust Belt turned to opioids for solace. And that might be true, actually, but it begs the question of why opioids, why white Americans, and why at that moment of the late 90s to early 2000s. So I'm going to argue that the opioids involved were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming white Americans. And the key to the story, I'm getting ahead of myself, the key to the story is an unrecognized form of ethnic marketing that, because it targets white Americans, works by not marking itself as racial. The story is invisible by design, and it was only through years of observation and interviews with key actors in this story that I was able to unravel the threads. So I've observed drug policy and addiction science meetings, clinical interactions, interviewed over 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, prescribers, and then additional patients. I'm going to start where I started the study, which is with Suboxone, otherwise known as buprenorphine. It's easiest to see its racial identity by comparing it to its predecessor, methadone. So here's a bar graph from the first nationally representative study to compare buprenorphine patients to methadone patients by race and class. And while I was at NYU, I was able to map where New Yorkers prescribed buprenorphine lived versus methadone patients, and saw a very similar pattern in terms of the race and class of the neighborhoods that they come from. And now at UCLA, my colleague there, David Streiger, did this map showing that neighborhoods with the best access to buprenorphine are actually the ones with the highest average income and the lowest overdose rate. So those neighborhoods with the highest overdose rate don't have access to buprenorphine. Recent national studies confirmed that white Americans with opioid use disorder are 3 to 4 times as likely to get buprenorphine as Black Americans with opioid use disorder, with most of the patients on buprenorphine paying for it privately out of pocket. This is a really expensive medication, followed by private insurance, and then much further down the list, Medicaid or Medicare. So that really tells you who's getting buprenorphine. What we don't know from graphs like the ones I just showed is by what process did buprenorphine and methadone get their racial identities. And for this, we have to go back in time. So we'll go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. And the unemployment rate for Black Americans is twice that for white Americans. Organized crime takes advantage of this to get control of Asian heroin imports, and they recruit a sales force from these Black and Latinx inner city neighborhoods with high unemployment rates. Meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency, analogous to insulin deficiency and diabetes, he publishes findings with co-authors from the first clinical trial of methadone maintenance. And the study's subjects are African-American heroin injecting men from Harlem. Its outcomes of decreased criminal activity and increased employment at 6 months brings it national attention. So by 1970, news of methadone as a pharmacological answer to the urban heroin problem reaches President Nixon, who appoints pioneering methadone psychiatrist Joan Jaffe as the nation's first drug czar. So Nixon targets inner city Black and Latinx populations, as well as returning Vietnam veterans, with methadone, which was the first major weapon in his war on drugs. And to prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring daily observed dosing and regular urine testing. That persists to this day. Those of you who've worked in a methadone clinic know what I'm talking about. And then due to community resistance, NIMBYism around location of methadone clinics, they are placed in marginalized neighborhoods remote from other clinical services. So in New York City, when I was working there, it was really remarkable that most clinic or hospital centers that had methadone programs located those methadone programs pretty far away from the parent hospital or clinic. So let's fast forward to October 8th, 2002. A new kind of opioid problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a quote unquote minimally addictive pain reliever. Most of the newly dependent people are white. Many of them are middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone and Suboxone, for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. So pharmacologically similar to methadone in that it's an opioid that blocks opiate receptors in the brains of patients who are dependent. Buprenorphine can be prescribed monthly for use at home by a prescribing physician, while methadone is still restricted to DEA-regulated clinics with directly observed dosing. Office-based buprenorphine represents a reversal of national policy. It's actually a really profound shift. It's the first time since the 1914 Harrison Act that private doctors are permitted to use opioids to treat opiate dependence in their office. So to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. Buprenorphine, pharmacologically in the same drug class as methadone, it's an opioid, it had to be whitened. And so this is Mike. Some of you may have gone to this website or sent patients to it. He's in an internet ad for Suboxone, otherwise known as buprenorphine. He's seated in his Ohio diner, flanked by American flags, talking about returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury at work. So this is a real reversal of the image of who is an opioid quote unquote addict. You know, this is not the image of somebody who's been addicted over the decades leading up to this ad. But I want to argue that the ad was just the tip of the iceberg and that the whiteness of buprenorphine was actively achieved by specific social technologies. So what do I mean by that? I'm going to give you an analysis of the contemporary white opioid crisis, or not so contemporary now. I think it's actually shifted yet again. But the white opioid crisis of the early 2000s in terms of what I call technologies of whiteness. That is social technologies of neuroscientific metaphors, policy, and industry strategies that maintain racial boundaries around the biomedical uses of opioids. And this scheme is informed by whiteness studies. It's a whole area of research in social sciences and social scholarship. It proposes that whiteness is a category of exclusion in the United States. So we have this one-drop rule, which was written into many state laws until just a few decades ago. So, you know, it's a concept of purity. If you're a mixed race person, you're not going to count as white in this country. It requires cultural and political maintenance of its boundaries. And white race is unmarked in general. It's the assumed norm in the US. It's rare, it has been up until recently, rarely explicitly named in the media or in public policies. And the coverage of whiteness in the presidential politics following that 2015 article, you know, by Ann Case and Angus Deaton that I showed, as well as the opioid deaths over the past couple of decades and the media references to white Americans, that's been the exception that has proved the rule. You know, it's really been a real shift from the prior pattern. I've also discovered the ways that when white race is being signaled in the media, such as in recent drug policy debates and in humanizing media coverage of the quote unquote new face of addiction, whiteness is signaled using code words such as suburban, while the race of Black or Latino people with substance use disorder is mentioned explicitly, most often in relation to crime. And then third, whiteness is defined by its other. White on the one hand, or Black and non-white on the other hand, are interdependent. So punitive American drug policy has long had a mutually defining twin of legal narcotics for white Americans, who have had access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, then moving to post-World War II barbiturates, stimulant diet pills, Valium, otherwise known as suburban mother's little helper, now back to prescription opioid pain relievers. And then lastly, white privilege has its costs. Not only do white consumers pay inflated prices for patented prescription opioids, they have paid with their lives, in the form of overdose by lethal substances to which they had quote unquote privileged access. And I'm just going to run through these 4 technologies of whiteness for you, starting with the least visible technology of race making, which is brain science. This is where it's hardest to see. So let's put buprenorphine development on the backdrop of President Bush the first's decade of the brain. This was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project and all of the biotech opportunities, economic opportunities that would come from that. In the process, NIDA renamed addiction a quote unquote chronic relapsing brain disease. And this was supported by leading NIDA researchers who co-authored this widely cited article in JAMA at the end of the decade of the brain. And in it, they argued that narcotics dependence is comparable to diabetes, hypertension, and asthma in terms of its heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. The scientists involved in this movement had a clear social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition and not a problem of morality or choice. What they didn't anticipate was that the scientific universalism of their brain disease model, because it implied a standard white male subject, it would help open white markets to new opioids. And they also didn't anticipate the unequal ways that biotechnologies are disseminated, that would enhance the social stratification of addiction with this brain disease model. So for instance, images like this, by taking out the subject and his or her trappings of gender, race, and class out of the picture, and actually literally by taking the offending organ, the brain, out of the body altogether, the image symbolically conveys an unmarked universality of addiction physiology. So you don't know from this image who this person is, where they live, anything about them, their context. Neuroscientists further reduced the causes of addiction to molecular action at neuroreceptors, the ultimate disembodiment of addiction. So the apparent universality of this molecular model implies an assumed white norm. It takes a problem long associated with Black and brown crime and gives it a new implicit association with white Americans, particularly in drug development for treatments. But in the process, it excludes social conditions. The scientists wanted to counteract a drug war mentality by erasing the social context of drug use, yet they paradoxically set the stage for a renewed racial stratification of opioids. So the next technology of whiteness is new biotechnologies. Neuroscientists unwittingly aided corporate strategists that capitalized on this erasure of the social. Building on the neuroscientists' ideology of technological solutions for addiction, in '96, Purdue Pharma got FDA approval for OxyContin as a quote unquote minimally addictive pain reliever suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush of the oxycodone inside the capsule to the brain. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as the quote unquote fifth vital sign, along with heart rate, respiratory rate, blood pressure, et cetera. And the drug reps who were promoting OxyContin and sister products by other manufacturers advised new opioid prescribers to direct OxyContin and sister products to quote unquote to trustworthy patients, quote, trustworthy patients, which in a national clinical workforce has been shown to signal among prescribers who suspect non-white patients of drug abuse. This terminology of trustworthy patients implied white patients. And this coupled also with the marketing materials, which underscored that with images of not only white patients, but white grandmothers, mothers, images of everyone who is not supposed to be addicted. Of course, what the model of addiction-proof technology left out was the social inventiveness of drug use. So OxyContin users interested in a rush of oxycodone to the brain really quickly learned to crush and snort or inject the contents of these sustained release capsules. And after steep increases in opioid non-medical use and overdose, public pressure mounted for an intervention. So in August of 2010, just as the original patent on OxyContin ran out, Purdue Pharma introduced its tamper-resistant time-release formulation, embedding oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve them for injection or snorting. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban, symbolically non-white street markets. After another biotechnology developed specifically in response to the white suburban and rural prescription opioid epidemic is buprenorphine itself, combined with opioid antagonist naloxone and branded Suboxone. So Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an opioid and is non-medically used, with street markets in many other countries in the world, the naloxone with which buprenorphine was combined in Suboxone caused withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed. So naloxone could not be absorbed sublingually, and buprenorphine also posed a lower risk of overdose deaths than other opioids. In the 1990s, NIDA subsidized Suboxone's manufacture with $23 million to test it for use in addiction treatment and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotics Schedule 2, which is where OxyContin and methadone fall, to narcotics Schedule 3, along with codeine cough syrup. This is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries, like malaria drugs. Suboxone's designation got it a patent extension through 2009 on a drug that was initially developed in the late 1960s. In a race and class stratified healthcare system, such as we have in this country, where access to general doctors is often limited to those who can pay, patented expensive technologies for private office delivery in themselves encode white race and middle class among the patients, the consumers. Okay, the third technology of whiteness is regulation. Although by 2004, prescription opioids overtook heroin as the primary opioid of abuse in the US, the arrest rate for their illegal possession, the prescribed opioids, was 1/4 that of possession of heroin, and arrests for illegal sale of prescription drugs was less than 1/5 that of arrests for selling heroin. Not coincidentally, the non-medical use of pain relievers at that time in the early 2000s was twice as high among white Americans than among Black Americans, while rates of heroin use among Black, Latinx, and white Americans were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused surveillance and enforcement on prescription opioid prescribers and pharmacists instead. And so I believe Minnesota has prescription drug monitoring program in place. And I don't know offhand how restrictive or criminalizing it is, but in New York State, for example, it could lead to criminal prosecution of prescribers or pharmacists that don't look up a patient in a database to see if they're getting narcotics prescriptions elsewhere. And so prescription drug monitoring programs were eventually enacted in all states. Returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act, Data 2000, was passed by Congress in 2000 and enabled any certified physician to prescribe Suboxone in the privacy of their own office. In congressional debates leading to passage of Data 2000, there's a clear emphasis on a, quote, new kind of user, one that's young, suburban, and, quote, not hardcore, end of quote. So that's language that implies white Americans and largely middle-class white Americans. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. So then Health and Human Services Director Donna Shalala was but one of many officials who noted that buprenorphine as an alternative to methadone would serve a, quote, new kind of addict, including citizens who would not normally be associated with the term addiction, end of quote. So with this racially coded language in which suburban, a new kind of addict referred to middle-class white Americans, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So Data 2000 kept the restrictive methadone system intact, and it did nothing to alter the drug laws that mandated inner-city heroin users to prison, but it did create a new treatment track for those with the resources to use it. To give additional assurance to the DEA that buprenorphine wouldn't spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course. Some of you may have taken this course. That was required for doctors to prescribe buprenorphine. It was the first and only prescription drug in the US to come with that kind of requirement for additional training. Public sector doctors that I interviewed at the time told me that the certification requirement was a major barrier to making buprenorphine available to low-income people because public clinics didn't provide time or incentives to pursue this kind of additional certification training, while prescribers in the private sector could charge fees of up to $1,000 for a half-an-hour induction visit. This was in New York City in the early 2000s. The shortage of public sector prescribers, along with the cost of the drug buprenorphine itself, long kept buprenorphine in the private sector. And then the last technology of whiteness is media and marketing. OxyContin's legendary commercial success hinged on its designation as minimally addictive, as an opioid analgesic. And when OxyContin was under review at the FDA, Purdue Pharma estimated the addictive potential of OxyContin to be less than 1% based on testing among terminally ill cancer patients for a 3-month period. In 96, the FDA accepted this claim and enabled Purdue to open an opioid market that had previously been restricted to those with severe acute pain, cancer pain, post-surgical pain. They were able to open the market to a much larger market of patients with moderate chronic pain, like lower back pain, that were seeing primary care doctors. They hired 700 drug reps who canvassed a call list of 100,000 physicians in the first few years alone. Purdue targeted general doctors in white, suburban, and rural areas, serving patients. Oh, and these are some images from ads at the time that were used to market it. So they targeted prescribers who were serving patients that the public and the DEA did not think of as at high risk for addiction. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, with disproportionate uptake of OxyContin and sister products. There were other manufacturers who hopped into this game. So disproportionate uptake of prescribers in white, suburban, and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. In a newspaper content analysis I completed, I found that in contrast to articles about the criminality of Black or Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or people struggling with physical or emotional pain. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulation of oxycodone, combined with new prescription drug monitoring programs, led many of these opioid users to look for heroin when pills became hard to get. And one consequence of this was a whitening of the media coverage of heroin users who'd long been portrayed as Black or brown. So this is an image of a school teacher in suburban upstate New York, and another one of a college athlete in Arizona. And these are just two of myriad images like this in the mid 2010s. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. Manufacturer-sponsored web-based public service announcements. I showed you an image from Mike's story. That was one of them. They featured white professionals and business owners on Suboxone maintenance. This same website features a link to a Suboxone prescriber locator service created by the Federal Substance Abuse and Mental Health Services Administration. So if you look in the lower left-hand corner, patients find a buprenorphine prescription, you put your zip code in, you get a printout of all the certified prescribers in your area. The vast majority of them are not going to be accepting public insurance. These are, or even insurance. These are people in private practice. So these strategies created an exclusive but lucrative segment of the market for Suboxone, making it a blockbuster drug. By 2012, in that year alone, it earned 1.5 billion in the US, and it was second in that year only to OxyContin itself, which reported in 2012 US sales of 3 billion. So it very quickly became a blockbuster. So in conclusion, as I'm hoping to have a conversation, and I actually should take a peek at the time here. Okay, good. So we have a little bit of time for discussion. The racial segmentation of drug markets into licit and illicit, white and black, clinical and recreational, creates a moving target of time-bound patents on new technologies for white middle-class consumers. And this is a very old cycle. It was started by Bayer Pharmaceuticals' own heroin, marketed as a non-addictive alternative to morphine among middle-class Victorian housewives in 1898. And also a highly effective cough syrup for children, as it turns out. But seeing as this is such a repetitive cycle, what can we learn from the story as clinicians, researchers, and even policymakers? So I want to argue that number one, magic bullets are a myth. As the failed promises of OxyContin's sustained release capsule showed us, and the inability of a unilateral focus on buprenorphine treatment to stem overdoses in this country has shown, biotechnology alone can't stop the harms of narcotics without systemic and social interventions. And against the magic bullet concept of addiction and treatment, it's worth noting that the 4 waves of drug use overdose that I started citing, it's become polysubstance use. So addiction is not rooted in a particular substance. This is not something we can eliminate by just pulling one substance out of the market, whether it's a legal or illegal market. Addiction is a set of behaviors that shift from one substance to another in responses to change in policy, drug markets, and definitely the social environment. And these behaviors need to be addressed at their root causes, at the level of policy, really social systemic structures. A single therapeutic compound can't solve the problem. So to underscore this point, I'm going to turn to an international comparison that's often used by American advocates for buprenorphine expansion, and that is with France. In France, where buprenorphine was adopted for general doctor treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent. I think I'm covering my camera. It was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and also HIV among low-income, largely immigrant heroin injectors. Buprenorphine was widely adopted among primary care doctors in poor communities in France, a country, I need to underscore this, a country with universal health care. So this is a prescribed treatment. They had universal health care to support that. The opioid overdose rate in France dropped 80% in the first 5 years after buprenorphine's approval. That's what this graph is showing. Contrast that with the US, where opioid overdoses are now well over 6 to 7 times what they were when buprenorphine was first introduced in 2002. So France, I mentioned, has a universal healthcare system. It also has a robust social safety net. And I just want to take 1 second to describe how buprenorphine is delivered in France. So they have community-based addiction centers that have not only access to buprenorphine and methadone, but comprehensive medical treatment, also mental health treatment, a network, community-based harm reduction services, peer navigation. It's a very comprehensive approach that builds on the social safety net that France also has in place. So it's not just medical treatment with buprenorphine. The other point from this is if you look at the French peak in overdoses in 1995, that's where, if you look at the blue graph, the one that goes down over time, it starts off at 565. Okay, so that number is 565 overdoses, not 565,000 overdoses as it might be in this country. So, they didn't actually have the same kind of overdose crisis that we had. It's 565 overdoses in a country of 60 million people. Why didn't they have an overdose crisis of the proportions that we have? Well, first of all, that the United States is one of 2 countries in the world that allows direct-to-consumer advertising of pharmaceuticals. So France didn't allow that. They don't even allow direct-to-physician advertising of pharmaceuticals. And they have a national review body that looks at new pharmaceuticals to see if the benefits outweigh the risks and the costs. OxyContin was never marketed in France. The review body determined that OxyContin the benefits didn't merit the costs. And they're also very strict about conflicts of interest. So people who serve on the national review body can't have connections to the pharma industry before, during, or after their service. So this alternative reality of France should make us skeptical about the power of the market to protect the public and rectify health inequalities. In our for-profit healthcare system, buprenorphine maintenance has followed the pattern predicted by theorists of fundamental causes of disease, Bruce Link and Joe Phelan, that new biotechnologies in a system like ours with wide social inequalities at baseline, if you market new biotechnologies, they will widen rather than narrow those inequalities. Even though pharmaceutical marketers and biotech marketers will hold up new technologies as the solution to health inequalities, the opposite will happen if social drivers of health aren't addressed. Then second take home is that problem drug use is a biosocial phenomenon. I think we have to reconsider what it means that addiction is a chronic brain disease. I don't argue with the fact that there are definite brain-based changes in addiction. Basic neuroscientists, though, are increasingly seeing the brain as a plastic, socially responsive organ that's evolved to adapt to complex social systems. So as a species, that's how we survive these complex social systems. And emerging life science models of neuroplasticity, epigenetics, and the microbiome, they underscore that human biology is not a fixed entity. It's dynamically shaped in interaction with the social environment. So these more sophisticated biological models inherently call on us to invest in research on the impact of social systems and on interventions that create healthy social contexts, including robust social services, recovery support networks that give dignity, meaning, and structure to people's lives. If we were to take seriously the comparison of drug dependence with diabetes, asthma, and hypertension, we'd recognize that each of these conditions has strong social determinants and that success in their treatment and prevention requires social support, access to fresh food, safe, unpolluted, walkable neighborhoods, and the list goes on. So we need to really focus on that and the neuroscientific implications of that. And then third, deaths of despair, along lines of Ann Case and Angus Deaton, they call for racial and economic justice. So Ann Case and Angus Deaton's landmark 2015 report on the decline in US white life expectancy was unusual because its authors were economists. They weren't physicians or epidemiologists, they were economists. And their analysis of root causes of overdose, as well as alcohol-related cirrhosis, and suicide lay not in neuroreceptors or genetics, but in the deindustrialization of American Rust Belt towns, where the departure of manufacturing and mining industries left behind high unemployment and social disintegration. A sociological study following their report showed that overdose rates were directly linked to thin social networks. So areas of the country that had social disintegration by measures of social capital were those with the highest overdose rates. Accordingly, Case and Deaton popularized the idea that overdoses were deaths of despair. And their argument is persuasive. It calls for social and economic revitalization through policies that promote social integration, stable employment with livable wages and benefits. So not just public-private partnerships to quickly develop, approve, and disseminate new medications for addiction, as were prioritized early on in the opioid crisis by federal initiatives. But Case and Deaton's focus on white Americans makes the analysis incomplete. It makes Black and Latinx overdose deaths invisible. Case and Deaton don't really explain why Black and Latinx life expectancy did not decline in the time period of their study. But I want to propose that Black and Latinx Americans saw an overdose crisis 30 to 40 years before working class white Americans, with the influx of heroin to inner city neighborhoods from the 1960s to 80s. Blue collar workers in Black and Latinx neighborhoods were often barred from unions, from labor unions. They were often last hired, first fired. They saw massive unemployment much earlier than their white worker counterparts, who were initially protected by industrial discrimination. This earlier Black and Latinx opioid crisis was not seen as a health crisis. It was reported in the popular press as an epidemic of crime, and it led to white flight from cities, further disinvestment from Black and Latinx city neighborhoods. I know Minneapolis and St. Paul saw a lot of that also. So we're left with the survivors of that earlier crisis, even as the CDC now reports that Black Americans and Native Americans are the group with the fastest rising overdose rate. And I mentioned the impact of mass incarceration on those statistics. So while we work towards race and class justice and economic policy, we should use concern about the opioid crisis to go beyond drug development and invest in one, universal health care. And I'd love to have a conversation about where psychiatrists fit into this, but we really need psychosocial interventions along with that. That's an area, even though our internist colleagues really took the lead with buprenorphine expansion, even they picked it up much faster than psychiatrists in many ways. What we haven't looked at is what we have to address in the way of psychiatric comorbidities, trauma-informed therapy, peer navigation, recovery support, assistance with housing and employment are also really key ingredients. That's the lesson from France. Second, we need to divert people with opioid use disorder and substance use disorder in general from the criminal legal system and promote treatment and harm reduction as a national response, not as local initiatives. Why do I focus on a national response? Well, in New York City, for example, there's a program in Staten Island called Project Hope that's diverted over half of those arrested for low-level drug charges from sentencing into treatment plus peer navigation. And they've had a lot of success with this. It's been held up as a model. So the problem with Project Hope is that it really for a long time operated only in Staten Island. And Staten Island is New York City's most affluent borough, whitest borough. It really hasn't caught on in the South Bronx, which is largely Black and Latinx, and now reports the largest number of overdoses in the city. So in the South Bronx, sentencing for drug crimes continues at high rates, and incarceration itself continues to be a major determinant of overdose post-incarceration. So as long as it's up to empowered communities like those in Staten Island who partnered with their district attorney to start Project Hope, as long as it's up to local initiatives to do this kind of work and start programs like this, decriminalization and treatment will focus largely on white and more affluent areas. And then lastly, biosocial and systems research and interventions are desperately needed. And I realize that this department is actually proudly leading in that area. So this is for colleagues elsewhere, where I argue that public resources should be moved from drug development of magic bullets, where they're currently focused, towards research on and implementation of innovative, integrative, biosocial community-based approaches. So these include peer-based recovery networks involving the arts, urban gardening, community-based organizations that offer spiritual and religious services. I could offer a lot of examples of this, and maybe we can have a conversation, but these approaches necessarily integrate medications with recovery networks of support, harm reduction, and social services delivered by trusted community members and peers. So that's where I think the money is, and we have growing evidence for that. There's so much more I could say about that part of it, but I do want to have a conversation, so I'll stop there. How much time do we have left?
We have 25 minutes.
Oh, wonderful.
Yeah,
Okay,
plenty of time.
great.
First of all, thank you.
Thank you.
It's really thought-provoking. I think,
Appreciate that.
opening, presentation. So I invite everyone online to put your questions in the Q&A, and I can read them as they come, and also here if anyone has a question or comment.
I have maybe two more comments than questions. You know, and you alluded very eloquently to it, particularly towards the end of your talk. And first of all, thank you for a fantastic talk. But
Thank you.
you know, it's also right. You talk about racial capitalism. I mean, you can't ignore the role of the prison system and the privatization of essentially incarcerating the most vulnerable individuals in our society, and talk about a life of despair, if not actually also deaths of despair, because we know the effects on mortality and longer term outcomes. And so it seems to me, and I'm sure probably there's a whole branch, right, of this is not my area, but I'm assuming there's probably a whole branch of research into the intertwining of this racial capitalism that you describe around the pharmaceutical industry and the racial capitalism of our prison system, which doesn't exist, for example, in France or other countries. The idea that you would privatize incarceration of your own citizens is abhorrent in other countries. So I'm just wondering if you had any
with
thoughts
entire
about that.
towns now being dependent on the carceral economy.
Right.
Yeah.
Which then necessitates the criminalization of
It drives demand.
right. Right.
Right. Oh, what an astute observation. And I think that's an area of overlap and convergence that hasn't been studied enough. I've seen a very curious disconnect between people who work on drug policy and people who work on carceral policies. And I would love to see those threads connected. So I think you're right. There are the same dynamics are at play. The companies that are profiting may or may not be the same companies, but they're working on a similar logic. So
and must have incredibly powerful lobbying forces. And then add into that the third part of that Venn diagram, right, is the criminalization of mental illness.
yes.
And so, right, you have this incredible profit motive. Why would you create the kinds of true treatment systems that you're describing if you have a whole sector that's going to see a reduction in its profits, right? How would they want to support that?
You're so right about that. So I have colleagues such as Ernie Drucker, who published a book called A Plague of Prisons, who modeled incarceration with epidemiological tools and showed that incarceration itself is a pathogen. So in communities that have high rates of incarceration, the community members that are left behind suffer much higher rates of premature death, infant mortality, and all of that. And taking a social science lens to it, what happens when a significant percentage of a community or members of a community are incarcerated is that you're losing productive members of families and of the economy. And so it tears apart, speaking of the social disintegration and the deaths of despair model, it tears apart the social fabric in those communities.
That's another factor into getting into your social brain, which is if you are embedded in a community where the example is of other members of your community being put behind bars, what does that, I mean, that must cause a sense of kind of internal stress, internal uncertainty, a sense that the world is highly not just unpredictable, but punitive. Right? So even if you're not incarcerated, you're moving through a community where that is your experience of what your community is suffering. And that's going to have long-term health consequences.
That is so well put. So one of my academic heroes with whom I've been able to partner on these projects is Dorothy Roberts. I don't know if you heard about her latest show. She wrote a book, Killing the Black Body, and then later, now I'm forgetting the title of the book, but it was about structural racism within healthcare. fatal invention, with the idea that race as an invention, social construct, is fatal. So her latest book is on the foster care system. And that's another offshoot of this whole approach to drug policy that we're taking, is that so many families are ripped apart because parents who test positive for drug use or have any kind of involvement with the criminal legal system are very, very quickly lose custody of their children. And it's also, that system has been privatized to a certain extent. So it's a nightmarish scenario where she cited the statistic that was mind-blowing at a talk that I heard recently, that 50% of Black American families have had some exposure to child protective services. And in Los Angeles, where I'm coming from, there in South LA, which is heavily Black and Latinx, majority of families have some exposure, and they're really high percentage of children that are in the foster care system. And when you start to think about what that does to their childhoods, their development, their, networks of support or not networks of support, identity,
their sense of safety, right?
Yes. And since I know Minnesota has a very strong presence of Native Americans, they can speak to the multi-generational impact of that, because they've had generations of children shipped off to boarding schools, to foster care, and have the disintegration of the social ties and the cultural identity. So drug policy and the way that we handle people with substance use disorder is literally tearing apart families and communities. It's literally doing that. So because this is such a depressing story, Debbie commented on that. She was reading my book, bless you, Debbie. And she wrote to me, this is such a sad story. It is so depressing. I'm not going to have time now, but I had some slides on structural competency as an approach to clinical training. And the whole focus is, what can we do as clinical practitioners to act on these social determinants of health and the structural drivers? How can we partner with community organizations? How can we partner with non-health sectors like schools, even criminal legal system, urban design? How can we partner with policymakers to address these root causes? Because we as healthcare practitioners do have a certain kind of symbolic capital. When we define something as a health issue, when we say, oh, housing, affordable housing is a health issue, because look how poorly people who have unstable housing do in terms of health outcomes, we can get a certain ear in policy circles. I usually end with that because we have to look for the light. We can't get frozen in depression about how bad our approach is. So I'll just tell a very quick story about a powerful counterexample to how we do child protective services and foster care and substance use disorder in this country. In Vancouver, Atira Women's Aid Society is an organization that provides housing for unstably housed women with, family-friendly units, and which over time got more and more involved in addiction treatment, recovery support, and also harm reduction. They have a women's only safe injection facility, now known as medically supervised overdose prevention facility. So they pioneered a lot of that stuff for the focus on women, particularly women who are subject to intimate partner violence. One thing they did was they worked out an agreement with the British Columbia Child Protective Services that women in their programs, even if they test positive for drug use, can keep custody of their children, because what they provide is round-the-clock childcare, early childhood intervention programs, and they can now brag about the outcomes among the children. They're having really great educational outcomes. The families are staying together. And what they're doing is breaking a cycle, a repetitive cycle of women who are using substances, who come from families that were pulled apart. Often they come from foster care. And then they, with their own children, are at much higher risk of problem substance use and then losing custody of their children. So it's a multi-generational phenomenon. The same thing with incarceration. It's multi-generational impact. And they've been able to break that cycle. It is hard to imagine a universe in the US at this moment where child protective services would go along with this, but we need to keep looking to models like that and start building support for drug policies that are going to put people first, that are going to say, well, what's the best way to get good outcomes? Because it's not just the individual at stake. Like you point out, it's communities, it's families. This is the foundation we're built on. So thank you for that, for giving me that opening.
Yeah.
And you're so right that this is an area of much more, we need much more research. We in psychiatry could be leading in that because we interface with the carceral system. We interface with child protective services. We could really be speaking up much more aggressively for this kind of approach. So thank you for that.
Well, one small thing which and now I have to think it through a little bit, which
Yeah.
we've done here, and I part of me wants to brag about it, but now having listened to your talk, I'm thinking I've got to think this, because there may be a side to this which I'm not seeing. But as an example of what you're seeing, advocating, we're a site for the Healthy Brains Child Development, HBCD new
Mhm.
you've been a little involved with that from peripherally, right? Hamid, we have one of our faculty, we have several faculty here, but one in our department. So this is a longitudinal study of mothers, including mothers who are at risk or who are themselves addicted, and who are entering pregnancy. And we'll be following them longitudinally through the pregnancy and as many years beyond as the funding will continue.
Mhm.
And it's to look at sort of multiple behavioral, neuroimaging, child development, maternal health, child health factors. But when the study was getting set to be designed and implemented here, they ran into various regulatory issues, including human subjects protection, saying, and legal oversight of that, saying, oh, well, there's no way we can allow people to sign informed consent for this unless you make it clear that if a mother,
Mhm.
a pregnant woman, is admitting that she has a drug use issue, she's going to be submitted to mandated reporting,
Mm.
which of course now sets up the vicious cycle you were
Right.
just describing. And our researchers in our department went to the legislature and said, you've got to change this here in Minnesota, because we need to allow women to voluntarily participate in this research so we can gain the long-term knowledge that we need without it automatically meaning that they're going to be reported or
Right.
be sent to child protective services. And they were able to get that changed.
Wow.
Yeah.
So much
Yeah.
credit to
Yeah.
you and the state of Minnesota.
So,
It's the HBCD project.
yeah.
Yeah.
So, yeah.
We want to acknowledge just one question.
Yeah.
From our online audience. So this is from Mate Beiser, one of our psychiatry faculty. The question is, how do you see the role of methadone and the methadone clinic model in opioid treatment going forward?
Hmm.
Given the changing racial makeup of the patient population, will it spread to the white rural communities, or will it fall out of favor due to Suboxone being available? Is it redundant or complementary? Will it become stigmatized?
What a great question. So there are many layers to that. I can say no, methadone is not obsolete. So first of all, there are many people who respond to methadone treatment that don't necessarily do well with buprenorphine. And those of us who've been in clinical practice, we know the value of having some choices and different tools. The problem with the methadone system right now is its punitive nature. It was founded on a semi-criminalized model. It was a war on drugs technology, the way that it was set up. Recently, I've been doing a lot of work with leadership of a group called the Urban Survivors Union. They've just changed their name to National Survivors Union. It's essentially a union of people who use drugs, many of whom are on methadone maintenance. And they've done citizen science, they did research, and wrote a piece called the Methadone Manifesto based on a series of surveys, focus groups, and things about what is working and not working for people who are on methadone, and what changes institutionally in terms of policy and regulation would have to happen for methadone to be a person-friendly treatment. And I highly recommend Methadone Manifesto. I was an editor for a special issue of the American Journal of Public Health. I think it was 2022 that it came out, where the authors of the Methadone Manifesto wrote about how they did the citizen science leading up to the piece. And in the National Academy of Medicine Opioid Collaborative, a group of us managed to get the Urban Survivors Union leaders who were key in that publication to be keynote speakers for a legislative review of methadone policy. And they were really powerful in talking about how the criminalized approach limits people on all levels who could be benefiting much more from methadone treatment. And they brought into view people who we often don't consider, people with disabilities, people who are rearing children, where the restrictive hours and the requirement, if you're in a rural area, wow, you have to go a long way to get to a clinic. And if you're required for daily observed dosing, it's just not feasible. There's so many ways. So they're recommending putting methadone treatment into community organizations, removing the requirement to have it in these really restrictive DEA surveilled centers. This would be an advantage to all kinds of groups, like LGBTQ groups. It greatly benefit from having trusted community-based providers, settings to go to. And so those were their recommendations. And I think their model of having people who are directly affected involved in structuring research that influences policy and speaking out on their own behalf is a really powerful one, because the federal legislators and regulators who came to that methadone policy workshop and heard Urban Survivors Union leaders directly commented on how transformed they were by hearing what difference it makes, how methadone is arranged. So there's a lot of activity right now based on the COVID experiment, the natural experiment, that there were certain states, and I'm not sure if Minnesota was one of them. There are certain states that under COVID allowed a lot more take-home doses. And there were, despite fears that we would see an uptick in methadone overdose rates, methadone diversion and street sale. And in fact, that didn't happen. So it was a natural experiment to say, look, you can actually make methadone much more accessible and user-friendly and not see negative consequences out in the community. So I think there is definitely a future for methadone. It's been very hard to get over its stigmatized roots, which is why buprenorphine advocates really had to sharply distinguish it. And unfortunately, these are just, when you're in a racial capitalist system and you're trying to market a new product, you have to use the tools at your disposal. And those tools will include racial imagery. If you're trying to market a product that's seen as risky in some way, you want to convey safety. And so in our racial capitalist system, you convey safety by showing a white, middle-class, often female, maybe even elderly consumer, because that's the opposite image of a risky patient or risky consumer. But now there's more and more momentum, I think, behind liberalizing methadone regulations, getting it out into community organizations and baking around it things like peer navigation, social supports. That was the original intent of many of the methadone founders decades ago, to have a lot of support systems and group therapy. And some programs still offer that, but many don't. So that's a long-winded answer. Oh, sure.
Thank you so much. I'll reach out to you separately.
Okay, thank
Thanks
you.
again. Wonderful
Great
that
meeting
you're
you.
listening.
Thank you.
We still have a few more minutes. There's a
Great.
couple questions. So one is to the point you were making, this is from Alex Furman,
Yeah.
that you've illustrated brilliantly how pharma has used race and whiteness to divide and conquer for profit. And with devastating results for everyone. But on the other hand, many Americans recoil from discussions of addressing racial inequalities. How do you talk about these issues in a way that bridges more people, who brings people together and builds consensus? This is such a
What a heavy question, and I would like the answer to that.
Yeah.
I would, but I have found that it's much easier to have these conversations now. Somehow I think we're kind of coming around as a society to more open discussion. Certainly the racial inequalities of COVID treatment and outcomes has, made it hard to run away, particularly among healthcare providers. The past few years discussion about racial inequalities in criminal legal systems, mass incarceration. Of course, there's a lot of divisiveness too and division coming out of that, but I'm finding it easier and easier to have these conversations with my colleagues anyway, and to a certain extent with people who are consumers, who are patients, who are, in the general public. So one thing that structural competency as a framework of an alternative approach allows me is a language that I think is a little less threatening and more accessible to a wide range of people. When we start talking about structural drivers of health, it seems as though it's easier to have that conversation than if I start off with racism. Racism can be such an overwhelming and threatening term to many Americans. And so starting off with a positive, first of all, people have to have something to work towards instead of something to run away from. It can be so paralyzing to be saddled with how dysfunctional our system is, and particularly racial inequalities, how baked in and seemingly unsurmountable they are. So, I try to really hone in on solutions, positive examples. How are people elsewhere doing it better? One thing I didn't mention about Atira Women's Aid Society in Vancouver, it's not the only example. I wish there were more, but there are more than Atira. But since I talked about Atira, a lot of their clientele is Native American, First Nations is what they call it in Canada. And so it also is a racial issue in that First Nations people in Canada are disproportionately trapped into this multi-generational community and cultural disruption, criminal legal involvement, substance use pattern. And so interventions like that really address root causes are also a direct intervention on racial inequalities in Canada. And so I think when we start talking about that, when we start talking about solutions, when we give really concrete interventions, when we are able to highlight how intervening on structural racism and racial capitalism really benefits everyone, that makes it easier to have these conversations, because then it's less of a dead end, depressing conversation. And it's so important to overcome cynicism. I think this is a period of time where either we give into cynicism or we really work towards alternatives and look forward. So I don't have the answer to that, but that's how I'm trying to go about it. And if the person who asked that question would volunteer a few other helpful hints, I'd appreciate it.
Yeah, this is seems like a heavy lift sometimes, but there's a question maybe, there's one question about how we as clinicians or researchers could participate in destigmatizing or maybe, equalizing some of these inequalities that are happening. I just wonder if you have some suggestions from, for people on the ground.
So maybe, how much time do we have? 3 minutes? I think I could do this in 3 minutes. I'm going to go back to my slide deck. Okay, because I have here, this is structural competency. I mentioned that. And I often distinguish structural drivers from social determinants of health, with structural drivers being, what can you do about the root causes? How can you change policy, institutional practices, instead of identifying, the social determinants, unstable housing, criminal legal involvement. And with structural competency, really borrowing from the social sciences around social structures. That's where you address root causes, and rather than looking just at the individual. And also competency, we as clinical practitioners can actually do something. We can develop skills to intervene at that level. And I'm just going to run through the different levels of structural intervention. So the easiest low-hanging fruit is, what can you do in the clinic where you're already practicing? So these are some examples: electronic medical records that have prompts embedded when you do assessments of social determinants that remind you to ask people about stable housing, access to fresh foods, and criminal legal involvement. Just doing that alone leads to a big uptick in referrals for social services. And then medical legal partnerships. I'm not sure if you have them here at UMN, but we across the country are seeing more and more clinical practitioners partnering with pro bono lawyers or law students to pursue cases that lend themselves. So, children who come in with lead poisoning and it turns out there's a landlord and you're seeing a pattern, can go after that. And that often will lead to policy change. So our patients in psychiatry often evicted by landlords who are violating Americans with Disabilities Act. So those are the places where lawyers can be helpful. Social prescribing, which is when a practitioner writes a prescription for, say, help with Social Security benefits application, hands it over to a peer navigator or a volunteer, and that person will walk the patient through the process. And then peer navigation itself, incorporating peer navigators and community health workers into the clinical teams. That in itself is a structural intervention. It changes the structure of the healthcare team. Then the second level of structure at which we could be as clinical practitioners working is partnering with community organizations. So here are 2 substance use oriented examples. On the right, my friend Ayana Jordan, who is a addiction psychiatrist who's pioneered putting addiction treatment and recovery support into Black and Latinx churches. So these are places that people trust and they go, and lots of peer navigation there too. So it's a lot less threatening than going to a biomedical clinic where often people with addiction histories are very strongly discriminated against. And if you happen to be of color, even more. So just a successful example with Native American versions of it too underway. And then the next level of structure, collaborating with non-health sectors. So schools, housing agencies, cultural arts organizations, and then even urban planners. This is Mindy Fullilove, one of my big mentors in life, who's a psychiatrist, who after years, decades of writing about how urban renewal and other urban planning policies disrupted Black and brown communities and led to a lot of the health problems we see now, started partnering with urban planners and architects to integrate cities as a health intervention, got great results in places like Pittsburgh, Pennsylvania, Orange, New Jersey. So as clinicians, we could be working with, we could be planning cities. And then last, policy advocacy. So that's an area where psychiatrists in particular have not been present enough. There's so many policy proposals out there with big implications for mental health that we could be speaking up about. Drug policy is an obvious area. This group, From Punishment to Public Health, was a group I joined when I was at NYU. Psychiatrists, public health researchers, formerly incarcerated people, and also disenchanted criminal legal system people who wanted to channel people away from the criminal legal system and towards mental health care when they needed it. And they've done a lot of creative stuff. But one of the things that I keep coming back to is that they train psychiatrists and other clinical practitioners to give testimony to policymakers. That's not a skill that we learn in medical school or residency, but it can go a really long way to know how to speak to policymakers. So those are just some examples. And that's my attempt to answer. What can we as clinical practitioners do?
Different ways how to start thinking outside of the typical biomedical box.
Yeah.
Thank you so much.
Thank you.
This has been wonderful.
Really appreciate your having me. Thank you.
And everyone, the CME code is 3577. Thank you. And the spelling of